Okay, so we will continue today with the fractures of the lower limb. First of all, we have to see these X-rays that are on this slide to a little bit understand what we see and to on the shoulder, the hip X-ray. First of all, you can see the anatomy of the hip, of course, with the head of the femur, the neck, the greater tuberosity, the lesser tuberosity, the fovea capitis, the place where the ligament from the acetabulum connects to the head of the femur, so it keeps it in place. The superior and inferior ramus of the pubis, and of course the line of Shenton. This is important because this line is an important thing to see. Sorry for a second. Să rămână? Da, Gabi. Lăsați-le acolo să vină. Am microcursul cu studenții și cum termin o să vin. Da? Lăsați-le pe foaie acolo și vin eu. Știi, am făcut o externare amargă. Lăsați-le acolo că vin eu. Cum termin cu studenții, vin. Da? Bine, mersi mult, să rămână. Okay, sorry for that. Okay, so this Shenton line, this is important to keep in mind because this line tells us if there's a fracture of the neck of the perohanteric region. When we have a fracture in this region, then this line will be broken. So it's not going to be perfect like this. It's going to be broken in a place. So this will give us information about the fractures of the proximal part of the femur. Next, we have the image that we see on the right inferior part of our slide. This image is most important for fractures of the acetabulum and the pelvis region. This image is not very important for you because they're not. Nobody's going to ask you this in the examination, the X-ray examination, but you have to keep in mind because this helps you understand different fractures. So we have the iliopectineal line. If a fracture is in this line, then we have a fracture of the anterior column of the pelvis. The ilioischiatic line, if you have a fracture, this we have in the posterior part. The roof of the acetabulum, this is important for fractures in the anterior column and the roof of the acetabulum. Posterior wall, of course, fractures in the posterior part, and the anterior wall, the fractures of the anterior part. Next, we see this image about the luxations that can be produced in the hip. We discussed this in the course, but I want to tell you a little bit more about them so you can keep in mind. When we have luxations of the hip, first of all, it's rather rare to have just a luxation. In most cases, we have also a fracture of the head of the femur or maybe a fracture of the acetabulum. What I'm discussing right now just when we have a luxation. The luxations can be posterior or anterior, and they can also be superior and inferior, both anterior and posterior. If we have a posterior luxation, as you can see in the first image, it can be superior or inferior, as you can see. And always when we have a fracture or a luxation in the posterior part, then the lower limb will be in internal rotation and adduction, as you can see. If it's superior, then it's the lower limb is extended, and if it's inferior, then it is flexed. When we speak about luxation in the anterior part, again, we will have superior and inferior. Both of them will be in external rotation and abduction. And when it's superior, it's extended the lower limb, and when it's inferior, it's flexed. Okay, so you keep in mind this image. It's very important for you to understand the fracture, the luxation that can be produced in this region. If the patient comes with this type of luxation, most of the patients that have luxation of the hip are patients that are young and have a high traumatic mechanism luxation. So a car accident or something like that. And I told you that it's a young patient because in most elderly patients, if they have this type of traumatism, it's not going to be a luxation, rather than it's going to be a fracture, because the bone is not so resistant as in younger patients. Next, the illustration about the fractures of the head of the femur. Luxation fractures of the head of the femur are very rare. Why? Because the forces that generate this type of fractures are very high, and in most cases, it's not going to be just a fracture of the head. It's going to be the fracture of the head with the luxation of the head. Okay, so it's not just going to be the fracture of the head. The Pipkin 1 is just a inferior fracture without displacement. Pipkin 2 is a fracture, transverse fracture of the head. 3, as you can see, is the fracture of the head and of the neck. And the Pipkin 4 is a fracture of the head with a fracture of the acetabulum, as you can see. Now you can see some images of the luxations, not just a drawing, but rather also a X-ray. You can see the luxation of the head in posterior. You can see here the image, the X-ray, and the illustration. As you can see, it is very easy to identify, but not so easy to treat. For all these luxations, they are emergencies, orthopedic emergency. We have to reduct this luxation as soon as possible through orthopedic means if we can, or surgical ones if the orthopedic means didn't have success. After we have reducted this luxation, the patient will have to have a trans-bony traction. You learned about this in the micro course. We will do a transbony traction through the supracondylar region of the femur. So we will take a Kirschner wire, we will take it and go through the supracondylar region of the femur, and then with the Brown immobilization, the Atella Brown, we will keep the leg in extension and a traction with a weight about 1/5 or 6th of the patient's weight. Again, a luxation of the fracture of the hip, that is also with a fracture of the posterior wall of the acetabulum. As I told you, just a luxation is quite rare. Most of them have also some degree of fracture of the acetabulum. Or maybe this type of luxation because of the forces that are not only from anterior to posterior, so not just a force that hits the patient's knee and produces the luxation. We have also a force that is compresses the head of the femur in the acetabulum, and we can have this type of commutative fracture in the acetabulum. Again, a fracture that in most cases can be treated through orthopedic means just by the traction. But of course, if we have a more commutative fracture in this region, as you can see here, again, this is the same mechanism, but with a higher degree of energy. The force that produces this type of luxation or fracture is with a much more higher force. As you can see here, the destruction of the both anterior and posterior columns of the acetabulum. In these cases, the treatment is through surgical means because the displacement is too high for just orthopedic means. So we'll have to put a plate of screws there and reduct the fracture as good as possible. Why is this important? First of all, because if we do not operate, then the hip will be unstable. And second of all, even if we cannot reduct it perfectly, we reduct it as much as we can so that in a second operation we can put a total hip prosthesis there. If we do not reduct it correctly, then we will not have enough bony tissue for the prosthesis. So this is important to reconstruct it for further treatment. The problem with these types of fractures luxations is that the arthrosis generated by them is very, very high, and the pain of the patient will be also very high through this destruction of bone. So most likely the patient will need a prosthesis in a second procedure, but we have to reconstruct as much as we can, so we will have a good bony capital, so we can rearrange it very good. Again, a fracture and luxation of the hip. The luxation is posterior and the wall of the posterior part of the acetabulum is displaced. Again, a fracture that has to have a surgical treatment because the hip will be unstable and it can produce luxation with much lower energies if we do not reconstruct it, because as you know, we don't have only bone here, we also have a labrum, we also have a capsule of the hip, and of course, if we have this type of displacement, also the hip, the labrum is destroyed, and also the capsula articularis is also destroyed, so we have to reconstruct it as good as possible. An image of the pelvis for you to see it again and keep in mind. The anterior X-ray, and that's just a drawing here, but you can see this also by X-ray. Anteriorly, we have the ilium, the ischium, and the pubis, and posterior, we have the sacrum and the coccyx, as you can see. Very important in this type of lesions, because next we will discuss about lesions of the pelvis. This is also an emergency, orthopedic emergency, because first of all, the vascularization, as you can see here, is very high, and the most problematic part of these types of luxations or fractures of the pelvis is the lesions of the veins in the posterior part, because there are a lot of plexuses there, and all of these plexuses, if we have a fracture of the posterior walls of the pelvis, will bleed a lot, and the hematoma that will be produced will be very high, and the patient will lose a lot of blood really, really quick. So this type of fractures must be treated as soon as possible, because if they are not treated, the patient can die through exsanguination. Again, we can see here the image of the pelvis, but also with the ligaments. You can see that a lot of ligaments are in the posterior part. Why is this? Because they give almost all the resistance of this region. The pelvis is not a very, very resistant structure, because it has a three-dimensional form, and through this, the anatomic of this region is not so resistant as other parts of our body. So most of the resistance of this part is through this iliolumbar, anterior and posterior sacroiliac, and the sacrotuberosity and sacrospinous ligaments. These ligaments give a lot of resistance, and of course, through a strong, a high energy traumatism, they can be destroyed and produce instability in this region. For this type of fractures, we have the tile classification. As you can see here, there are three types, the A, the B, and the C. It's very important to keep in mind that fractures of type 1 tile are fractures that are not unstable, are fractures that, as you can see, can be in the parts that are not in the articulation, the alaris bone, or the pubis ramus, or maybe in the sacrum. So these fractures do not produce instability, they just produce a lot of pain, but not the instability. So the patient doesn't need a operation as soon as possible. But it's a different discussion when we speak about B and C. As you can see, in type B, we have a rotational instability. Okay, so we have a fracture in the anterior and posterior part because the pelvis is like a ring. When we have a fracture in one part, it's almost 100% possible, maybe not 100%, but 90% possible that we have also a fracture in the posterior part. Why? Because if you take a ring and you break it in the part, then you will see that a lot of force will be applied on the remaining posterior part. So exactly the same is the hip. So if you have a fracture here that produces this rotational instability, so it will produce lesions also in posterior. We also can have this type B, that is the type 1 is produced by forces that are applied from anterior to posterior. When we speak about type B, we have forces that are produced from lateral to medial or medial to lateral. Okay, and type 3, we have a fracture that is in anterior in one part and not on the same part like this one. So here is fracture here on the same part. Here is on the right side is a lesion, and in posterior is on the left side. And type C are the most unstable of them. They are unstable also in rotation, but also in a vertical plane. So these fractures appear from the patient if he falls from a higher level on his feet, for example. So he doesn't have only lesions that produce instability in rotation, but rather also in vertical plane. All these type of fractures need a surgical intervention because it is the only way to reduct them. You can do a surgical intervention in emergency. You just use a external fixator or a C-clamp just to reduct it so the patient doesn't bleed out. But in a second operation, you can use plate and screws to reconstruct it as good as possible. Very important when we speak about the hip are some things. First of all, we have the vascularization. Okay, we told you a lot of times that the vascularization of the hip and the head of the femur is terminal. So we have a vascularization that comes from inferior and goes to the head, but we don't have something that comes from superior. We only have the ramus in the ligamentous that is between the acetabulum and the head of the femur, but this ligamentous vascularity doesn't give only about 1/5 of the vascularization, so it's not so important. Rather, this vascularization from the inferior part, from the profunda vena femoralis and the circumflex arteries, this is the one there. These are the ones that help vascularize the head. The problem with this vascularization is that, as I told you, is terminal, and second of it, as you can see here, it produces another anastomosis of the vascularization on the neck. So it's important, I will discuss again about the classification of the fractures, to understand exactly where the fracture is and see how it can produce the destruction of this vascularization. Second of all, are these lines of tension that are in the hip. As you can see here, one is from this side and one is from the other side. We have this wart triangle where we don't have any resistance, and here is the most predominant place where the fractures can be produced, because where the lines are, the resistance is much higher than in this place. This is important once to understand exactly how the fracture is produced and why it appears in different parts. And second of all, because through the operation, we will do a hip osteosynthesis, we will have to put our screws and our orthopedic reduction methods in the regions that are with the most dense bone tissue, okay, so for greater resistance. And of course, we have some ligaments here as in our body that keep the hip in its place. So this image is rather pathognomonic to fractures of the hip. If we speak about the peritrophanteric or the neck of the femur, if we have this external rotation, we have abduction and the shortening of the leg. If we have a fracture just of the neck, the shortening will be not so high. But if we have a fracture of this trochanteric region, of course, the movement of the femur will be to superior, and the shortening will be more important. Okay. We have this type of classification. First of the three that we will discuss, the Delbecq classification. This is the most simple of all of them. It just classifies the neck of the femur in three parts where the fracture is: the subcapital, the mediocervical, and the basicervical. Why is this classification important? Because when we discussed about the vascularization that comes from the inferior part and the capsula articularis, as you saw, it comes in this region. So if you have the fractures of the subcapital region or the medial cervical region, the hematoma that will be generated by this fracture will be intra-articular. So if it's intra-articular, the pressure generated by this hematoma will make a lot of compression on the vascularization, and through this compression it can produce the destruction of the vascularization. So when we have these types of fractures, the treatment must be in elderly patients directly total arthroplasty, but when we speak about younger patients, we will try to reduce it. The risk of avascular necrosis is very high, but in very young patients, we have to take this risk and try to do a osteosynthesis, because the destruction of the head can or cannot be produced. And if we put a total hip arthroplasty in a 40-year-old patient, for example, or maybe even younger, because this type of fracture can appear even in 24, 26, 30 years old patient. If we do a total hip arthroplasty in a 30-year-old patient, it will be a problem, because this prosthesis can be degraded in time and he will need reinterventions, and reintervention. So he can have a lot of reinterventions with increased risk of septic evolution and of dislocation of the hip. But when we discuss about elderly patients, 70, 80 years old, the direct treatment is the total or hemiarthroplasty, because we cannot operate. We can, but it's not very easy to operate a very elderly patient a lot of times. When we speak about the basicervical fracture, it is a fracture of the neck, of course, but it is extra-articular, so the risk of avascular necrosis is much lower than in the other two types. So in this type, it's much easier to try a osteosynthesis. The next classification is the Powell's classification, that helps us understand the pattern of the fracture and how it can displace our fracture. First of all, we have the type 1, that is under 30 degrees. As you can see, the forces come from superior to inferior, and if this fracture is at less than 30 degrees, there will be forces of compression. The forces of compression will help the bone heal. If you have between 30 and 50 degrees, the risk of shear forces is higher, and of course, when we speak about more than 50 degrees, of course, all the forces will be shear forces rather than compression forces, as in this fracture. So this is a highly unstable fracture with the risk of displacement and risk of destruction of the vascularity. And third, the most important classification, that is a combination between the first two, is the Gardner classification. In this classification, we have to keep in mind those lines of resistance that we discussed earlier. You can see here the normal hip. You can see the first grade, the Gardner 1. It is a fracture that is only unicortical. So a fracture that is stable and can be treated through osteosynthesis. The second one is again a fracture of the whole neck of the femur, but a fracture that has a minimal displacement, and again it's stable, so we can use osteosynthesis. When we speak about 3 and 4, we have a displacement, as you can see here, an important displacement, and in Gardner 4 we have a total displacement of the neck and the peritrochanteric region. So these are very unstable fractures that in most cases in young elderly patients need a total hip arthroplasty. So some x-rays to see the fractures. We have the Shelton line, as we discussed, the normal Shelton line, and you can see here if you take a line here, it is broken here because we have a subcapital fracture in this region, as you can see. We can try and reduct it. As you can see here, the fracture was here. We tried and reducted, first of all, under X-ray with Kirchner wires to see the perfect introduction of them in the neck of this is the neck. So here is the posterior part, and this is the anterior part of the neck, and they have to be in the middle of the neck and have to go like 2 or 3 millimeters below the corticalis of the head, because here is the region where the resistance is highest, as I told you earlier. So for the fractures of the neck, we can use this type of osteosynthesis, or this type, the DHS, dynamic hip screw, DHS, sorry, dynamic hip screw. But it's very, very important when you have a fracture of the neck to use an anti-rotatory screw. Why is this important? Because, for example, if we just introduce the DHS, when we produce the reduction, the problem is that after we go inside with a Kirschner wire that is very small, after that we will come with a special drill that has a important diameter, almost as much as the screw. So when we will introduce this drill inside, through its rotation, it can rotate the head of the femur. So that is important to put, first of all, this type of screw, the anti-rotation screw, and then reduct it with a DHS. Now we see a fracture of the neck in an elderly patient. How do we know that an elderly patient? He already has arthrosis on this part, and this part. This space, articular space, is smaller. So it's an elderly patient that, of course, needs a total hip arthroplasty. The arthroplasties are not only all of them total. We can have the hemi-arthroplasty with the Moore hemiarthroplasty, or the Thompson one. The Moore is uncemented and Thompson is cemented. Hemiarthroplasty means that we only take out, we make an osteotomy of the neck, we take out the head of the femur, and then we put there the prosthesis that is just in this part. We do not change the acetabulum. Then we can use a bipolar total. We can use a bipolar prosthesis. This prosthesis also has only one, also changes the part of the femur, but it's not only it's not monoblock, so it's not just one device, it's rather two. So we have the head of the prosthesis that goes in a special cup that goes in the acetabulum. And of course, the total hip arthroplasty, as you can see in this image, we have this type of prosthesis that has three parts: the femur part, the head, and the acetabulum with a insert. When we continue, we discuss about fractures of the peritrochanteric region. As you can see in this image, they can be minimally displaced, they can be just intertrochanteric, a comminution of the trochanteric or trochanterodiaphyseal fractures like this one. It's easier to understand when we see the Kyle classification. The Kyle classification helps us understand and treat these types of fractures, because it explains to us how the fractures are displaced and how unstable they can be. So first of all, we have the type 1, so undisplaced. Sorry for the Romanian, I didn't change it in English, but I will explain exactly what's written here. So first of all, we have the type 1, it's undisplaced, it's stable, without comminution, almost 20%. Okay, so you can see here, undisplaced, just a fracture line without any comminution. Say type 2 are again stable, but with comminution. They are stable, as you can see here, a little bit displaced, but they don't have comminution, only 1-2 fractures. These are the most frequent, 36%. Then when we speak about the type 3 and type 4, we speak about unstable, comminutive, and with important posteromedial destruction. So these lesions here are very important, because when we speak about peritrochanteric fractures, we can have two types of treatment. First of all, three types rather. One of them is functional, so no operation, but we take that out. We remain with, we can use the DHS. When we speak about type 1 and type 2, the DHS is perfect because the plate will be on this side, the screw will come like this, and it can do very important compression in the region and generate bone. But when we speak about type 3 and type 4 that are unstable comminutive fractures, we have also fractures in the posterior medial part and the lateral corticalis, And of course, you can think if you put a plate here and a screw like this, it will do compression here, but not in this fracture. There will be no compression. Here will be shear forces. That forces will be only on the plate. So through this force, it can destroy the plate and destroy our whole osteosynthesis. And of course, in this, again, the comminution is very high, and the reduction that the DHS can do is not very important. So in these types of fracture, the type 3 and type 4, you will use a gamma nail. So for type 1, type 2, DHS, type 3, type 4, gamma nail. And of course, but that is something that nobody will ask you, in very, very, very comminutive fractures, you can also do a total hip arthroplasty with a special type of prosthesis that is a reconstruction type of prosthesis that will reconstruct all this region. But that is not important for you because nobody will ask you this. You keep in mind DHS, gamma nail. Okay, why is gamma nail better here? Because gamma nail has a centromedullary rod and the screw, and this centromedullary rod will have an axial resistance. Yes, so this will help us a lot in this type of fractures. So a periotrochanteric fracture that is type 2 chyle, it's easy to treat through DHS. Again, intertrochanteric fracture, or better said, a basicervical. Yeah, so this is the fracture at the base of the femur, and also here through the trochanteric region. Again, stable fracture. You use DHS to reduct. But as I told you, when we have fractures that imply the lateral part of the femur, it's important to use a gamma nail to treat it, because the gamma nail will be axillary force, as you can see here, and it will generate better bone and better results than the normal DHS. We also can have fractures of the greater tuberosity, the greater trochanter of the femur. In these types of fractures, the Hobanage method that can be used, as I told you, in the olecranial region, for example, can be used in these types of fractures, again, with very good results. Of course, if we speak about fractures of the diaphyseal part of the femur, as you can see here, we can have fractures that are just transverse. We can have bifocal fractures. We can have highly comminutive fractures in this region. If they are in the upper and middle part of the femur, it's better to use a long gamma nail, as you can see here, because it has more stability in the proximal region. You can use also just a centromedullary nail, but that will not have the same stability as the gamma nail. So in fractures that are in this region, it's better to use this type of long gamma nail to reduct the fractures. If you have fractures in the lower part, if you have fractures in the middle part, just use a normal centromedullary nail. And if you have fractures in the lower part of the femur, you can use a retro nail, okay? So if the fractures are in the upper part and the neck, long gamma nail, in the middle, normal anterograde retro nailing, and if they are in the inferior part, you can use retro nailing. They come from inferior to superior, and they can help us a lot in reducing this type of fractures. We can have also fractures in the distal part of the femur. As you can see here, they are somewhat similar to the ones in the condylar region of the palata humeralis. They are fractures that can be produced superior from the condyle, supracondylar fracture. They can be simple, they can be comminutive. We have fractures of the condyles, anterior, medial, posterior, of course, anterior and posterior, and why not the comminutive fractures of the femur, as you can see here, with important displacement of the fractures. So supracondylar, as you can see, comminutive fractures. When we have only a fracture of the condyles, you can use this type of osteosynthesis with screws. Always use 2 screws, not only 1, because if you use only 1, the segment can rotate around that screw. So it's very important to use two screws to immobilize that segment. Okay, they can be anterior or posterior. And of course, we can use also the DCS, the dynamic condylar screw, as you can see it here. You can use an angle plate blade, as you can see here. We can use retrograde nailing, but not for this type of fracture. And why not the LIS and condylar plates? These are specialized placed auto-locking plates that helps us reduct as good as possible the fractures that we see. The fractures of the patella are also pathognomonic because it's very easy to see, patella being directly under the skin. Always in the fracture of the patella, we will have an important displacement of the bones. Why? Because the forces are very high in this region through the quadriceps muscle and the patellaris ligament. They will pull on the bone, and in most cases of transverse fractures of the patella, it will be very displaced. So in most cases, we have to operate. Of course, if we have not a transverse, rather a longitudinal fracture of the patella, the displacement will not be so high. In most cases of fractures of the patella, you can use this type of hobanage that helps the patient move as soon as possible. It helps us because it transforms all the forces that make traction of the bone in forces that make compression. So after the operation, the patient can walk and have a normal function of the knee. The next discussion, I didn't put X-rays, sorry for that. I should have put some images here because it's easier for you to keep in mind these types of fractures through the images. We have fractures of the plateau of the tibial plateau. We have the Schatzker classification. I'm sorry that I didn't put it here, but you can search on internet Schatzker classification. There are 6 grades. We have the displacement of this part. We have the compression and displacement, and then just compression of this part. Then we have fractures of the medial part. We have fractures of the medial part and the lateral part, and we have fractures that go through the whole metaphyseal part, as you can see here. So this fracture is a type 6 Schatzker. Okay. For this type of fracture, the treatment is mostly surgical because it's a fracture that implies the lesions of the articular surface, and all lesions of the articular surface are problematic because they generate arthrosis. So in most cases, we use plate and screws. For type 6, as you can see here, we have to use 2 plates because it helps us reduce the fracture. But for example, in type 1 Schatzker, when we have only the displacement of the plateau, the lateral plateau, we can use 2 screws to reduce it. Or in Schatzker 2 or 3, we can use just 1 plate on that side that helps us reduce the fracture as good as possible. Next, we have the fractures of the tibia, and most likely the fracture of the peroneal bones. These fractures appear through direct, most of them appear through direct traumatism. For example, a pedestrian goes on the sidewalk and the car hits him directly in the tibia, or indirect fractures. For example, a sporting lesion in the winter sport, when he makes a pivot on the lower limb, and this pivot can make a spirate fracture of the bones. Most cases of this type of fractures are treated through centromedullary nailing. As you can see in this image, we put a nail through the bone, and it helps the patient walk as soon as possible. So the next day or the second day after the operation, he can walk without problems. Next, we have fractures of the lower third of the tibia, the supramalleolar fractures or the pilon fractures. The fractures that can be supramalleolar are just as the name tells you, just above the malleolus of the tibia. The pylon fractures imply also the articular surface of the bone. As you can see here, these fractures is supramalleolar. It doesn't have fractures in the articular surface. And the treatment is through plate and screws that helps us reduce the fracture. This is a pylon fracture, so a fracture that implies the malleolus, but also the articular surface. As you can see here, there are two lines of fracture that will produce a lot of arthrosis for the patient. So it's very important to use this type of osteosynthesis. Once this plate helps us reduce perfectly the articular surface, and this plate has only one screw because it's a plate that only blocks the movement. Only blocks the movement, the medial movement of the bone. So it's just a comfort plate that blocks this type of movement. This is the plate that reduces the fracture, and this is the plate that helps reduce the peroneal fracture. Fractures of the malleoli can be the tibialis malleoli, the peroneal malleoli, or both of them, and of course can be also the third malleoli. This is the posterior part of the pylon that can produce displacement. They, in most cases, need to be treated through surgical means because they are fractures that imply the articular surface. As you can see here, for the tibial malleoli, you can use the Hobonage method because, again, we have forces that will produce traction in this region, and the Hobonage method helps us reduce it. And of course, you can use this type of plate to reduce the peroneal fracture. Next, we discuss about fractures of the calcaneal region. We have to keep in mind two classifications, two angles, the Böhler and the Guisson angle. The Böhler angle is produced by two lines, one that goes through the articular surface between the calcaneus and the talus in the upper part, and the second one comes from the most higher part of the anterior articulation of the calcaneus and through the tuberosity of Achilles. And this angle has to be between 20 and 40 degrees. Why is this important? Because when the angle is a lot smaller or a lot bigger, then we have a compression or a too important displacement of the fracture, and this problem is generated through arthrosis and pain in the patient. And the Guisson angle is a line that goes from the superior part of the articulation to inferior and from the anterior part to inferior. This angle tells us about the articulation between the calcaneus and the talus, and lesions in this angle are produced also in the articulation, so this will be problematic for the patient. You can see here a lower and decreased angle of Böhler, so we don't have this normal volta plantaris. We have a almost rectilineous plantaris line, and this is problematic because the patient cannot walk so good without this. This volta plantaris helps us a lot in our movement because it takes a lot of shock when we step. And then we have the SS Lopresti classification that helps us understand the degree of comminution in the fracture and, of course, the displacement of the bone. We have the tongue type fracture when we have a fracture in this region, and through the traction of the Achilles tendon, have the displacement of this part. And the second one, the depression fractures, when we have the destruction of the articulation. These are fractures that need surgery to reconstruct. You can see here a comminutive fracture of the calcaneus region that can be treated through plate and screws. You can see it's a specific and different type of plate, or of course you can use Kirchner wires. The last thing that we'll discuss, but you also discuss in the course today, are the gonarthrosis and coxarthrosis lesions of the of the knee. You can see here the same patient with different degrees of gonarthrosis. We can have here a lower degree with just a compression, a smaller articular surface medially, and the larger one distally. And this one, that is the last grade, the complete destruction of the articulation. We don't have any more articular space. Also displacement of the knee in varus, and a lot of osteophytes and geodes. The treatment, of course, is the only one, the total knee arthroplasty, and the arthrosis of the hip. You can see here no more articular space, osteophytes, destruction of the head of the femur. Again, the treatment can only be through total hip arthroplasty. Okay, if you have any questions.